Good afternoon. We're going to talk now about what's happening with injectable drug regimens for HIV. And here, of course, are my disclosures. We will start with the two drugs that are most advanced in their clinical development, long-acting cabotegravir and long-acting rilpivirine. Of course, you're all aware of the ATLAS and FLAIR studies, the large registrational studies that were designed to allow approval of these two formulations. They are now approved in Canada, but in no other countries, and are expected to be approved in the United States within the next 6 months. These two large randomized studies showed equivalent virologic efficacy for the two-drug combination of cabotegravir and rilpivirine as compared to continued three-drug combination oral antiretroviral therapy. That was true for ATLAS, and for FLAIR, nearly identical results. That is the same virologic outcomes for the injectable regimen as for the comparison oral regimen. Now, of course, it's important to keep in mind with these studies that despite the excellent efficacy, there were a few cases of resistance in both studies. In ATLAS, which started with patients who were already on antiretroviral therapy, there were 3 cases of resistance, all of which involved resistance to the non-nucleoside reverse transcriptase inhibitor rilpivirine, but in addition, 1 case of resistance to cabotegravir. The plasma cabotegravir and rilpivirine concentrations at the time of failure were below the population means, but within the range for the large majority of individuals who maintained virologic suppression. For the FLAIR study, which involved treatment-naive patients, the results were very similar. 3 cases of resistance by the end of 48 weeks, 2 of those cases involving resistance to rilpivirine, but all 3 of these cases now involving resistance to cabotegravir. In addition, the ATLAS study had an extension in which patients were randomized to continue every 4-week injection of the 2-drug long-acting formulations or every 8-week injection of the same formulations. And at the end of 48 weeks, the efficacy results for the 4-week regimen or the 8-week regimen were nearly identical, as shown in this presentation from Turner Overton at CROI this year. However, I think it's important to note that there was also resistance in the ATLAS 2M every 8-week arm. And in fact, compared to the every 4-week arm, there were more cases of resistance with the every 8-week regimen than with the every 4-week regimen. In fact, 4 times the number of resistance cases in the every 8-week regimen as in the every 4-week regimen. And we'll speak later in this conference about why that might be. So to remind us about where we are with long-acting cabotegravir and long-acting rilpivirine, resistance to this regimen was unusual, but it did occur. And in phase 3 clinical trials, resistance was always seen in patients with subtype A virus, which is found most often in East and Central Africa and Eastern Europe. Most patients who developed drug resistance had the L74I polymorphism in the HIV integrase gene at baseline. And in addition, most of these patients had cabotegravir and rilpivirine concentrations that were in the lower quartile as compared to other study participants. We'll talk later about the implications of that. And finally, I think it's important to keep in mind that although resistance was rare, it was more common with the every 8-week regimen than with the every 4-week regimen. Now let's talk about injectable cabotegravir, not just for HIV treatment, but now for HIV prevention. And we're going to share the results of the HPTN 083 study, which was a pre-exposure prophylaxis regimen containing long-acting injectable cabotegravir in cisgender men and transgender women who have sex with men. These data are from a presentation given by Rafi Landovitz at the virtual IAS meeting in July. Now, the design of this study was randomized and double-blinded and double-dummy. And so every participant got either cabotegravir injection or injection placebo, and every participant got daily tenofovir and emtricitabine or tenofovir and emtricitabine placebo. So there was a 5-week oral run-in to assure safety for people randomized to the cabotegravir arm. And following that 5-week run-in, the patients were begun on either injectable cabotegravir every 4 weeks or injectable placebo. So this was a very rigorous study design to determine whether an every 4-week injection of cabotegravir would have benefit in prevention of acquisition of HIV. Now, at the end of the primary analysis, there were a number of infections in both the cabotegravir arm and the tenofovir emtricitabine arm. However, there were substantially more infections in patients who were randomized to the oral regimen as compared to the injectable regimen. In fact, there were 3 times as many infections with oral tenofovir and FTC as compared to injectable cabotegravir in this study that had nearly 4,500 participants. So this was a highly statistically significant result in favor of injectable cabotegravir as a PrEP agent for HIV. And I think that the results of this study are really unequivocal in indicating the value of an injectable every 4-week cabotegravir formulation for HIV prevention as compared to oral therapy. And as you can see in the intention to treat analysis with the Kaplan-Meier plot, the benefit of injectable cabotegravir occurred really throughout the 3-year follow-up of this study. It looks like there are more failures in the oral arm in years between year 2 and year 3, but this is really, I think, an artifact of the small number of patients who were at risk at this point in the data analysis. So to conclude, both agents were highly effective, but the PrEP regimen containing injectable cabotegravir was superior to the daily oral regimen with a 66% relative reduction in risk as compared to daily oral tenofovir and emtricitabine. Injectable cabotegravir was well tolerated despite common injection site reactions. And we don't yet have the data on the drug concentrations and resistance profiles for those who failed therapy, but those will be important to understand and contextualize these results. Cabotegravir is the first long-acting injectable agent to demonstrate robust HIV prevention efficacy in men who have sex with men and transgender women. And there is also a parallel prevention trial, HPTN 084, that is ongoing in cisgender women, comparing the same 2 regimens. I want to now switch and talk about some of the novel drugs and novel formulations under development for HIV treatment and prevention. And we'll start with the capsid inhibitor, formerly known as GS6207. It now has a generic name, Lenacapavir. So we'll have to get used to calling this drug Lenacapavir. In July at Virtual AIDS 2000, colleagues from Gilead and their academic collaborators presented data on the pharmacokinetic profile of Lenacapavir given subcutaneously in HIV negative volunteers. Lenacapavir, as a reminder, is the only drug in development which is a HIV-1 capsid protein assembly inhibitor. And it is being developed in both a subcutaneous and oral formulation. This was a randomized, double-blind, placebo-controlled, single ascending subcutaneous dose trial in seronegative participants. And as you can see from this pharmacokinetic profile, in the comparison of 3 different dosing regimens, a 300 milligram 1 ml subcutaneous injection, a 1 ml 900 milligram injection, or a 1.5 ml 900 milligram injection, a single subcutaneous injection of Lenacapavir at the 2 higher doses, 900 milligrams, produced concentrations above the target, which is 6-fold higher than the protein-adjusted inhibitory quotient, for at least 6 months. And so this study suggests that Lenacapavir could certainly be given as an every 3-month injection and may very well be given as an every 6-month injection in larger clinical trials for HIV treatment and prevention. I want to move now to non-erodible implants and talk specifically about Islatravir. The Islatravir implant uses technology that is already widely used for the delivery of the hormonal contraceptive etonogestrel. And this figure shows the size and shape of one of these etonogestrel or Nexplanon implants with a photomicrograph of the cross-section of that implant. This is a technology that was already available to Merck, who are developing Islatravir, and it was therefore logical to use the same technology for delivery of this novel anti-HIV drug. The Islatravir pharmacokinetics really focus on the intracellular triphosphate. Islatravir is a nucleoside analog, although it has a different mechanism of action from other NRTIs. It is a terminator of extension of the RNA-DNA duplex, even though it has a 3' hydroxyl group, unlike other approved antiretroviral nucleoside analogs. It also has a very favorable pharmacokinetic profile with a long intracellular half-life for its active metabolite, the triphosphate. And when this drug is delivered as an implant with very slow release, it also has a favorable pharmacokinetic profile in HIV uninfected human volunteers. These are data presented last year at the IAAS meeting in Mexico City by Randy Matthews, showing 2 different formulations of Islatravir, a 54 milligram implant and a 62 milligram implant that were inserted subcutaneously for 12 weeks. And what you can see is over the 12-week period of monitoring, the concentrations of Islatravir triphosphate in peripheral blood mononuclear cells were really fairly constant. And once the Islatravir implant was removed, the triphosphate was eliminated from peripheral blood mononuclear cells at a rate consistent with that seen when Islatravir is given orally. So there's no evidence of a reservoir for Islatravir, that is, the drug is only being released from the implant. Now, a modeling exercise suggests that this implant, the 62 milligram implant, the higher dose implant, could deliver effective Islatravir concentrations for more than 1 year with a single implant. And these are data showing the projected Islatravir triphosphate concentrations based on that 12-week study I just showed you, with the projected population mean of Islatravir concentrations for the intracellular triphosphate out to 52 weeks, as compared to a pharmacokinetic threshold for prevention, which would be 0.05 picomoles per million cells. The lower curve shows the plasma concentrations of this drug after oral dosing with a very good fit to the pharmacokinetic model. So there's obviously a lot going on with injectable antiretrovirals, and I look forward to the opportunity to answer your questions and to discuss this with you as the day progresses. I would like to thank those who shared their data and their slides with me, especially Marta Bofito from Chelsea Westminster and Sue Swindells from the University of Nebraska. Thank you.